Okay, dokie. Let's make a move. So welcome all to a discussion about the DIMPLES study. Again, thank you so much everyone for joining in. Much like Brung started, it's amazing to see so many people being able to come together at such short notice to kind of join in with the PERUKI spirit and ethos about kind of collaborative research. So what's going to happen is Caroline, the principal investigator for this study, is going to give a bit of a background to the study. We will have then a discussion from Mark about actually the data requirements and how REDCap's going to work. And then we'll leave time for Q&A at the end. If you can try and keep yourself muted, if you're not speaking, that would be great. We are recording this though, so we will be able to share it with those who aren't able to attend either in other departments or within your own department. If you need to ask a question, please either put it in the comments bar, or if you have the function to kind of stick your hand up, we'll do that. What we will probably do though is I'll get Caroline to present and then keep the questions at the end of that section and do the same for Mark, rather than try and do them in real time. So I hope that makes sense. Yeah, and just for those, if you've just joined, please can you put your name and your site details in the chat so we've got a log of the event. Right then, Caroline, over to you. So if you want to share your screen.
Thank you, Damien. Thank you so much for coming to this session on DIMPLES, everyone. This is a PERUKI study. We're looking at children and young people presenting with diabetes mellitus to the emergency department during the SARS-CoV-2 pandemic. So really, we're looking at pediatric diabetes through the eyes of the emergency medicine clinician. For those of us who work in the emergency medicine department, we know how exciting it can be, and also somewhat magical. These children come to us, we see them first. They come with such varied pathology. And in that 3 hours and 59 minutes that they spend with us, we learn so much. And perhaps we should be the ones to tell their story. So I think emergency medicine is a specialty in its own right. Do you agree? Yes, you do. I can see some nods over there. So now, having covered ourselves with glory, let's go on to the actual business of DIMPLES. So just to put this in context, I'm dividing this into 5 sections. First is why we are doing the study, what we're hoping to find, how the study came about, what are the outcomes that we expect, and what are the challenges we expect. DIMPLES is a retrospective multi-center study to be done across the UK and the Irish departments. So who are the people we're interested in? All children aged about 6 months to the age of 16 years with new onset and existing diabetes who present to the emergency department. The time period of interest that we've chosen is March 1st, 2020 to February 28th, 2021. And this will represent the different waves and will be called the COVID-19 era. For comparison, we've chosen March 1st, 2019 to February 29th, 2020, and that will represent the pre-pandemic era. So what are our aims? Our aims are to describe the incidence, the clinical and the biochemical characteristics of new onset pediatric diabetes presenting to ED in the pandemic, and to evaluate if there is a temporal relationship to COVID-19. We also want to evaluate if there is an increase in the incidence and severity of DK in the pandemic in new onset and children previously immune, and of course to compare the findings to the pre-COVID historical data. Just briefly about how the study came about. I work at BHRUT, a hospital where we have 375 children with diabetes. Normally we see about 40 to 45 in a year. This year has been a high incidence year for us. We've seen 58 children with new onset diabetes. So what we normally see is a peak incidence in January with the winter viruses. But in summer, you see a trough. That was not the feature in 2020. This seasonal variation of pediatric diabetes is reported internationally, and that's pretty much the picture we see, except in 2020. In July 2020, we saw 2 to 3 children presenting with type 1 diabetes in a week. They presented with moderate and severe decay, some with pH as low as 6.8. The parents reported that their symptoms are very different. They had polyuria and polydipsia for a few days, sometimes up to a week or two. This is not the way type 1 diabetes presents at all. So there was a signal here. And then the question was, is there a relationship to SARS-CoV-2? I remember in July, Mark wrote to me about a different PERUKI study. And I wrote back to him and said, there's something pretty odd that I'm seeing over here with type 1 diabetes. We spoke on the same day over the telephone, and I actually told him the exact same things that I'm telling you now. And the next morning, he sent a research proposal from PERUKI, and that's how this study was born. I'm hugely grateful to both to Damien, Mark, and Rud, been very supportive in the study, and also who believed in me at a time when there wasn't much literature on or data on pediatric diabetes. What you're seeing here is a significant increase in pediatric DKA. This is again BHR data, and we're looking at only January to August. And if you look at the comparison, you can see that the presentation in 2016 with DKA is much lower compared to 2020. So why is this important to us? DKA is a high morbidity condition, and presentation of a child in DKA also affects long-term glycemic control. So we want to capture these children who present with T1DM quite early to prevent them from going into DKA. And lots of public awareness campaigns has happened. In spite of that, 25% of children who present with new onset diabetes do present with DKA. However, in the pandemic, this increased significantly. Literature started to trickle in quite slowly. The first is a study from Germany, which looked at 532 children and 217 pediatric diabetes units. And you can see that increase in DKA in 2020, 44.7% versus 24% in the previous 2 years. Another study from Italy, again comparing the first 2-3 months of the pandemic. Here there was not much variation in DKA between 2 years, but you can see the proportion of severe DKA has gone up, 44.3% compared to 36.1%. In a low volume condition like pediatric diabetes, that is still a significant increase. The third study came from Australia in January, and that looked at 5 years worth of pre-pandemic data. And you can see the numbers there, 73% increase in DKA in 2020 versus 26% in the previous years. Also significant increase in severe DKA, 45% versus 5%. The fourth study came in August from UK. It looked at 30 children, but the study describes pretty much what was happening in BHRUT. A high proportion of children in DKA and a lot of children with severe DKA in shock needing PICU. So I'm just giving you a little preview of network data, a study which was done across 12 PDUs, comparing 2020 with 2019. In absolute numbers, the incidence of DKA was 79 in 2020 versus 49 in 2019. Went back and looked at previous years, and you can see here, in 2016, 17, and 19, about 25% of children with new onset diabetes presented with DKA, whereas in 2020, it was up to 44%, quite agreeing with the international data. Again, this is regional data. We may find that nationally representative data is a little different from this. So it does get curiouser and curiouser with COVID. And I wanted to highlight one case. We've seen pretty much similar cases in BHR, but while you're doing the data, you might come across a couple of these index cases. This is a 13-year-old Afro-Caribbean girl who presented to BHR with 2 weeks of polyuria and polydipsia. She was very clever. She made a self-diagnosis of T1DM after looking at her symptoms on the internet. Parents weren't hugely impressed. They said, it can't really be, you're a good body weight, you're eating well. But 4 days after she made a diagnosis of T1DM herself, she presented with difficulty in breathing, abdominal pain, and vomiting. Parents rightly contacted 111. They were asked to monitor her condition and keep a close eye. Mother tells me that she deteriorated quite rapidly over the day, and she went on to become quite unresponsive. Parents put her in the back of the car and brought her to BHR. When she came to us, the pH was 6.86 with a blood glucose of 44. Her GCS was 9. She was in shock. So diagnosis of new onset type 1 diabetes was made with severe DKA, in shock, and cerebral edema was suspected. Her nasopharyngeal swab was positive for COVID-19. We started the treatment here and we sent her to PICU, Well, she did really well. She spent 48 hours over there and then went on to subcutaneous insulin. Very good clinical outcome, and she's now on subcutaneous insulin. She was positive for both ICA and GAD antibodies, suggesting that she was already predisposed to type 1 diabetes. Another interesting feature about her in PICU is that she had severe pain, abdomen, and vomiting. So they ran a panel of amylase and lipase. Amylase was 1,200 markedly elevated, lipase was 350. So with her clinical and biochemical symptoms, the diagnosis of pancreatitis was also made. So you see how SARS-CoV-2 can affect both the endocrine as well as exocrine part of the pancreas. A third thing emerged as well with her. We know that children with T1DM can develop autoimmune thyroid disease and celiac disease as they go along, but it's very rare to see them presenting with that at diagnosis. She had a markedly raised T4 and a suppressed TSH, and we ran a panel on her for thyroid receptor antibodies. That was raised, and she was also confirmed Graves' disease. So you see the number of pathologies that are going on over here. It makes you wonder, is SARS-CoV-2 responsible for T1DM in this child? Is it responsible for the decay? Is there a delay in presentation? Several questions arise from this. Going back to DIMPLES, we will be using anonymized data. We'll be entering it onto the validated online data entry software, which is REDCap. Mark will take you through that. I just wanted to leave you with this data from February and March, again from BHR. You can see the clustering of cases of T1DM, 4 to 5 cases presenting in a week. None of this is particularly reflective of type 1 diabetes and how it presents, even with the winter virus rays that we see. So there is a link, but is it going to be easy to prove? Causation is going to be really difficult to prove, given the sensitivity of the test that we're using. So we have to be aware of that. The other challenge is some of the units have closed their emergency departments and children will be coming to CDU. So there is a challenge in capturing this as well to include in our cohort. So this is about pediatric diabetes and the emergency department. I think it can be a bit challenging to do a specialty study in the emergency department, but I think we can do a really good job using national representative data that we're getting. Any questions that you have, just ask. You can ask that now, or you have my email. You can ask that later as well. Thank you.
Brilliant. Thank you very much, Caroline. Do you just want to, if you want to turn off your sharing, and we can go back to the full screen. I may have missed it, but I don't think Caroline shared the fact that she's in a unique position of being essentially an endocrinologist who's found herself working in the greater specialty, which is children's emergency care. So has a unique perspective of both. Now, if there are any questions, can people either raise their hands, wave, or stick it in the comments. The thing that I just want to highlight is Caroline's shared some really nice data about kind of trends in DKA diagnosis. For some of you on the call, you may be thinking, well, why are we doing this if some of this data is available, or won't other people be doing it? And I think the unique insight that kind of Caroline has realized is it's not just about whether diabetes has increased through COVID. As Caroline says, that there's various mechanisms by why that might work. And the thing that we can do, probably that no other group can do, is look at how that child appeared when they arrived. And I think that to me is the crux of what this particular study is about, is has the emergency presentation of the child with DKA changed in the COVID times versus pre-COVID times? And we're in a unique position to do that. And that will provide interesting data that is different from what the data the diabetic registry can provide, what the data that PICUs can provide, etc. So I think that's a real crux issue here. Any questions? I'll give kind of 30 seconds or so just for people maybe to muster up a bit of confidence. I know asking the first question can be a little daunting and scary. It shouldn't be. We're all friendly here at PERUKI. No one gets shot down. Okay. If you've arrived a little late and haven't put your name or site in the chat, please do so. Okay, there may be more questions to come. Mark, shall I go over to you just to go through the data entry?
Lovely. Hopefully you can see my red cap screen now. Data entry, the most exciting bit of the study. So it's an absolute pleasure to talk through this element. Look, it's absolutely fantastic to see 31 people on the call today, and that really lets us get off the ground running quickly. Heidi spent a lot of Friday sending out invitation packs to sites, so they should be with your R&I teams by now. There are more going out over the next few days, and that means that we can move forward with the data collection phase of this before very long passes. So what we want to do today is just go through REDCap in general and specifically focus on some of the data entry. One of the really important bits for this is to make sure that the data are as clean as possible, and also from my point of view to make sure that you know what you're doing as well as possible when we start, so that it all makes sense when you see it. So the plan for data entry from today, part of the reason why I'm asking you all to put your name and site into the chat, is that when we come to write the manuscript, we will put in the methods that everybody was trained in how to enter data. So this will serve as that training session, and that's why people will be able to watch it back afterwards as well. But it's important that I know that you've had the training. Once I know you've had the training, then I'll set you up with your own REDCap account in the system, and you'll be able to have a look at things. Where this lives is currently within the NHS, so I'm going to go through things for everybody. There may be some differences for Irish sites. At the minute, I've got a chat with Michael Barrett, who's taken on the lead on that from an Irish perspective, just to figure out exactly where REDCap is going to live in Ireland and how the data is going to move around. But it will either look identical to this or very similar to this. So there's no wasted time for non-NHS sites today. I will send you out your kind of REDCap logins to your NHS emails that you've given me before. If you haven't given me one already, please do so, and I can issue that to that address, and that just keeps it clean from this end of things. Otherwise, the institution gets very antsy about things, and then you'll be able to log in. So when you get that email through, there'll actually be two emails that come through. The first one will be to tell you that you have access to REDCap, and it will ask you to set up a password. The second email will tell you that you have access to the project itself. The project for this week is going to be a practice version, so it's not going to have absolutely everything in there, but we will go across to a live version probably next Monday. And what I'll do is I'll just delete the practice one from the system, so as you can't email it, you can't access it anymore, and you'll get another email telling you that you have access to the live version of things. When you are in the practice version, please, please, please don't put any patient information in there. You can use sample notes. You can make things up as you go through, really just to get a feel for it. But when we get to the live version, I'm going to have it all set up so that you cannot see each other's data. So if you work in Leicester, you will only see Leicester's data. If you work in BHR, you will only see BHR's data. On the practice version, you'll see, for at least the first half of this week, everybody playing with things while I build what are called data access groups that start to build that level of restriction in. The other thing about this is that there are no identifiable patient data in here, so we will be asking you to keep a log at your site that marries up the REDCap ID and one of the patient identifiers. Whether you keep that on a Word document, Excel spreadsheet, we'll send you through an Excel spreadsheet that you can use for that, but that will come in handy just in case there are any data queries on down the line or anything like that. That's all the prelude. I'll go in now to how to enter data for a patient. Your screen won't look exactly like mine because I've got far too many projects on the go at any one time. You will only have one, maximum two projects if you've got test and live at the same time. I'm just going to go to the Dimples project, left click to enter, and that takes me to the setup page. This you will not see. You will see the project homepage instead. That's all my workings in the background. To enter a record, I want you to go to the add or edit records button and then add a new record. You can see that that will open up a page where you have 4 forms that you can complete that relate to different elements of either identifying the patient or entering the data on the way through. First one to complete is the study ID. We do want to know where you're from. It should give me the option that if I type a few letters in here, it will give me a couple of options to select. I'm going to put one in for Bristol. Your code we will send out to you. I know that Bristol's code is BRI, and I'm going to make this 001. I'm going to mark the form as complete and save and exit the form. You can see that this gives me a lovely green dot. So we've got lots of color coding within REDCap. Gray means that no data has been entered yet. Yellow means there are some data in there, but you want to check on a few things. First, it's unverified. Red means you've started the form but not finished it. That's incomplete. And green means that you've done everything that you think you need to do, and you can control that all on the bottom drop-down list at the bottom of every page. I'm going to move on to the baseline demographics form. And you can see here we've got a number of the baseline demographics. We do want you to, wherever possible, enter an IMD decile. At the minute, we've found tools for England IMD and Scotland IMD, and it should pick up from the site that you enter where you are and navigate you to the right page. Once that page opens, you just enter your postcode, get your IMD. That's a 9, so we go back. And again, on a drop down, it's a 9. Choose an ethnicity. I'm not going to put my weight in here. I just want to say that we want the weight from the first presentation and ideally the height from the first presentation during the study period. So if the patient comes multiple times, if you can just enter this once for their initial presentation during the study period, that would be fantastic. This will shout at me if I don't enter them, but I'm going to say just now that I don't have access to a height. So you'll see the field instruction below it. If you don't know it, please record 9999. This is type 1 diabetes. Oh dear, I've made a bit of a mistake. REDCap thinks because there are validation limits on here. However, I can override these and you will get that warning message anytime you don't know something. So don't be surprised when they pop up. That's all normal. You can close it and carry on. For the sake of speed, select all these. And we have here a list of chronic comorbidities. So that's things which exist, and there's a definition here to keep you right. So it's conditions expected to last more than a year, requiring hospital specialist follow-up. I'm going to say we've got a few things going on, and you can see at the bottom that a few extra boxes are popping up now. These will only pop up whenever you answer questions that drive the logic to open those. So it's all set up with adaptive questions. But to save myself getting bogged down in the form, I'm going to click the no comorbidities. REDCap knows that if I click that, I shouldn't be clicking anything else at the same time. So it will ask me if I want to clear them. Indeed, I do. We'll move on to the family history. And again, the same rules apply there. I'm going to mark that form as complete. And instead of going back to my home screen, I'm going to move straight on to the next form here, which is about the initial presentation during the study period. So this is for the first attendance between 1st of March 2019 and 28th of February 2021. We need to know what month it is because we are asking some COVID-related questions from the 1st of March 2020 onwards. Before that, you will not trigger all the COVID questions. So if we answer October 2019, no change. All of a sudden, if I change that up and go for October 2020, we're heading into the COVID contacts and symptoms stage. Again, just follow the instructions on the way through. Any positive contact, any symptoms. This was a new onset. Severity. I think it's quite difficult to remember all the definitions. And so for that reason, Caroline and Ruud have put together an SOP to come with the study, almost a data dictionary. So as you can go back and look over the definitions of these things. But also what REDCap can do is if we hover over this for mild DKA, it'll pop up a reminder. I don't know whether everybody can see this because sometimes it doesn't come through when you're sharing the screen, but it has popped up a reminder to me The venous, for mild DKA, the definition is venous pH 7.2 to 7.29 or bicarbonate less than 15 millimole per liter. So that's the range that we're in that does that for each of the severities. If you want any other tweaks like that in the system, let me know. This is you doing all the hard work. So whatever I can do to make things easier, please do let me know. Pick a couple of symptoms, move on. And again, these are all essential fields so that we have nice clean data at the end. There is always the option for not documented. We want the number of days before presentation. Throughout this, the terminology is ED, but I'm aware that some people work in CAUs, and that is also fine as well. It's wherever that patient goes to first. We want from the onset of the first symptom to the date of attendance, and if somebody has written 2 months worth of symptoms, please count a month as 30 days and do some maths. We want to know about acute coexisting diagnoses as well as the chronic comorbidities. So if during the course of the illness, somebody also had asthma or wheeze, or was on steroids or had infection, we do want to know about those, please. But it just relates to that episode of decompensation rather than anything else in the background. And we also want to know whether any treatment-related issues contributed, such as whether they could access medicine, especially during the COVID era, whether there was any setup at home that contributed to things. We'll just say they left the drug at home. Then we want to know some of the physiology. So ideally, we'll take whatever you can get your hands on as you go through this. Again, there will be some where you can't get information. There will be some where it's pretty clear. And I'm just going to make up some numbers as I work my way through. So hopefully that will be well documented in the notes. There will be some where it's not, but the more complete the data, the better things will be. We imagine all of these patients will have had a pH and a blood gas. So hopefully you'll have information for this as well. And again, there will be limits on it. I think some units still use millimeters of mercury, whereas if most have gone across to kPa, but we'll just watch and see the trend in that. It may be an unnecessary question, and if it looks unnecessary after the first month or so of data entry, we may remove the unit question and just switch everybody on to kilopascals. Lactate, that's okay. We want to know whether it's a base deficit or a base balance, or base excess rather, sorry. And we also want to know some questions about the management as well, whether fluids were oral or enteral, how the insulin was initially administered, whether or not any inotropes were given, etc., and how long the patient stayed in hospital. We also want to know where the patient went, what happened to the patient on disposition from the ED and throughout the hospital attendance. And again, for this, it may be that they started off admitted to an inpatient ward, but ended up on PICU because they developed cerebral edema. So we want to know all that apply there, please. On to the acute blood results. One thing I will do whenever I email out instructions is I'm aware that some places may have different units for some of these results down here. So I will ask you all to tell me what units you use. And if we're all using the same units, great. We don't need to add an additional question. If we're all using different units, then I'll build that in, much like has been done with the CO2 in the previous section. So let's pop in some numbers. Oops. Okay, and COVID PCR testing at the bottom. If they've had some COVID tests done, there will be more questions. We'll want to know the result and whether they had serology. And again, it will only ask if they had it done. So that's that form complete. And that is all the data entry for each attendance that you need to do. So the first two forms, you only ever need to complete once. That form, that level of information, you'll need to collect for every patient. However, I want you to use that form only for the first presentation during the study period. And for any subsequent presentations, we want it logged against the same case, but on this separate form. You can see that it's identical to the form that we've just been through, so I'm not going to labor the point and work through all the data there, but I'm just going to leave it marked as incomplete and save it for a specific reason. You can see that whenever I don't fill stuff in on REDCap, I can come back to it later on. It will tell me off a bit, but it will let me leave. The reason why I wanted to fill in that form is that you will have some patients who will have had multiple attendances during the study period. And this is also why we need you to keep a log at site as well. So I can see here the study number that I've entered for the patient as we've worked through the test system that pulls through there. I can see that I've done the first 3 forms. I've not got all the data for the subsequent presentation, but I also need to enter another presentation during the study period. To enter the details for that presentation, we need to start a new form. And the way that we do that is clicking that button, and that will create another version of that form that will live within the system as well. Again, asking all the identical questions. Just going to save and exit that. You'll see now, whenever you go back to your status dashboard, that that patient has multiple little circles overlying each other. And you can see that you can access either of those subsequent presentations from there or add a new one, or you can navigate to the patient's homepage by clicking on their number, and you can see these multiple presentations below, so you can access any of those. I don't want to labor it any more than that. It is exactly that difficult and exactly that simple. It's one of those systems that becomes intuitive the more that you access it. Very often, the most difficult thing to do is get onto it in the first place. And then once you're in, it should make life easy from then on in. I would ask that everybody, when they get the link to set it up, does go ahead and check whether they can access it. We know that this works for all sites in the Health and Social Care Network. We also know that some local IT will block access to various things in quite an unpredictable way. So this is a really good opportunity to test whether or not you can actually access this at your site. And hopefully it should all be plain sailing and just a matter of unblocking something at your end if there are any challenges accessing it. So I will stop sharing there and pass over for any questions. Caroline, is there anything that I haven't covered in there that you want to talk to?
No, that's perfect, Mark. Everything is covered.
Brilliant. Thanks, Mark. So the one question from Chris in Nottingham: if we can enter negative values for basic excess deficit, does selecting excess versus deficit offer anything?
Yes and no, in that you could just enter the negative values. However, what do you call it? Do you call it base balance? And is that what everybody understands by it? Which is why we just went for base excess and base deficit. If everybody feels that actually base balance describes it and they'll put in either a negative or positive value, we can drop that question. It's all about data cleanliness, I think, Chris, in that what we don't want is people forgetting to put the negative in. So that was a bit of a drive in logic for why that was there, so that it was very clear that you definitely meant a base deficit.
Chris, is that a reasonable solution? I think it sounds a bit funny. It is just because of that reason. If someone doesn't accidentally misses out the negative, that is a problem.
Yeah, it makes it. It just confused my head a little bit, because I never see it as a spectrum that goes from negative to positive, and I like clean data, but I also get confused easily. You know that.
Yeah. Thanks, Chris. Right. So from Sophie, newly diagnosed patients well enough, they stay for a few hours and then go home again, bringing them back. So is it part of the same episode as first presentation form enough? We may have to think about that, unless Mark, Caroline, you've got an immediate response.
Yeah, so I would think pragmatically on that, and I'd be interested to know what Caroline thinks. For me, if you're bringing somebody home and ambulating them, in essence, it's part of the same decompensation episode, and that's what we're trying to capture, is the decompensation episode. So I think absolutely fine to just use the one form for that, if that makes sense, the one episode logged, rather than having to fill in multiple forms for the same episode of decompensation. I'm not sure if that's answered the question.
No, I agree. That sounds fine, Mark.
Yeah, that makes sense to me. Thank you.
Thanks, Sophie. Then a data entry question from Caroline. So what are the limits for values that can't possibly be possible? So on REDCap, if you put in 4 9s, that is you've forgotten the data. But if you put in 999, for example, would REDCap read that as your heart rate?
So REDCap will give you a warning. I'll just show you how it works behind the scenes for anybody who hasn't seen how REDCap works in the background if we go to the designer quickly. So if we look at some of the physiology behind the scenes, what we've done is we've set something called validation on this. So validation allows you to set the type of field that you are developing, and it also allows you to put limits on that based on the type of field that it is. So if I can just find, for example, the heart rate in here, and we look at the coding behind the scenes. So I can see that this is the heart rate field, it's called HR, and down here is where I'm doing my validation. So it has to be a number. It will not accept text. We've set a minimum value of 60 and an upper value of 160. That means if you enter any number outside of that range, REDCap will pop up a warning that says, it's okay to put that number in, but we just want you to check first that you really mean that number. So you can go ahead and put in the 9999. And what that allows us to do whenever we do the data analysis is that we code the stats program so that they ignore values of 9999 and they focus on the other values. So it's essentially a check and balance system rather than anything else, but it doesn't stop you from doing it. And we know that when we pull it out, we have asked you to enter the 9999, and it's an impossible number, and it's designed to be that big so that it is definitely impossible. And then we can carry on with the analysis.
Okay, I can't see any more questions in the chat. We have a good kind of 10 minutes left for that. Most people have Zoom has turned the videos off to save power. So if I can't see people waving at me, but please do shout out if you had anything. It's again, amazing to see so many people on the call. I hope that you think we've designed a system that is relatively fluid. One of the great things about this particular study is that it can be, even you as site leads can work with others to get people to fill in the data. And most of the data is pretty self-explanatory. And so it should be pretty easy to complete, even if you're kind of bundling some of your cases together. I suppose one of the issues that Trust may have is, can you collect all your diabetic presentations together? DKA and diabetes are ECDS codes, so and there aren't many other things that you can code instead of that. So they are pretty easy to find with your business analyst team. And the numbers aren't going to be massive. Ruud, I see you've joined as well. I don't know if you had anything to add or wanted to say that we may have missed so far.
No, thank you, guys. Hi, all. Wonderful seeing so many of you online. And thank you, Caroline and Mark, for your presentations. Just wanted to say that we will open up a Dropbox as well with all study documents. So they should be sent via your research and design units, but we will also make them available for you just as a source of information. Most of the people joining are sort of site leads. If you've got people helping out with data entry and contributing significantly to the study, just give their names to us so we can acknowledge them appropriately at the time of writing up this manuscript. And I think that's it for now. And really looking forward to our continued collaboration and seeing the data come in.
Fantastic, brilliant. Good. Actually, question a bit about when we start, actually, that'll be good. So when are approvals and when are we ready to go? And when are we going to close data collection? That's a royal we. That's going out to any of you other three.
So I will let Caroline decide when the stick has to be waved in terms of when we're going to complete data collection. But just in terms of the processes now, so Heidi, on behalf of the sponsor organisation, has begun the process of sending out the information packs to all sites. So I know a number of people, I think 23 sites received those on Friday. She's going to work through the rest of them over the next few days. If you haven't already let me know that you definitely want to do it, please do let me know, and then I'll let Heidi know to go ahead and send out the information pack. That will go to your research department as well as to the site leads. If you see that come through as a site lead, please do get in touch with your R&I to let them know that you're expecting it and that you don't require significant support from them. Otherwise, they may get bogged down in the red tape at their end. Whereas if they know that there's already somebody badged against it, it's just going to be waved through. That should be absolutely fine. Certainly across a lot of sites, it's not universal, but what happens next is that the research department then issues their approval for the site to participate in a process known as confirmation of capability and capacity. You officially have to wait until you have that confirmation of CNC before you start data entry. But I think that we can all begin the process of pulling out the notes, identifying patients. I will make the database live from next Monday for anybody who gets CNC quickly. And if anybody does enter data in there before they have CNC, I will not delete the data, but just be aware that if you do that, your research department may get upset. So please think about your future relationships with the department as well, is the way that I would phrase that. I've just seen another question pop up about patient consent. We don't need patient consent for this one. This is a retrospective chart review study. It's been approved by the HRA as a non-consenting study because we are essentially abstracting routinely collected data into this. So we don't need to contact patients or anything like that going backwards in time. And that's also part of the reason why we are not entering any identifiable data into the live database. And we want you to just keep the local records there. So I think I've answered most of it. Caroline, it's over to you. We want people to start as soon as possible. When do you want it all finished by?
Yes, please start as soon as possible. And I was thinking, is 1st of July a reasonable option? Because we have the NPDA data coming as well. Ours will be the largest national and possibly the international representative data set as well. So if you can get in there as soon as possible, that would be great.
Great. I agree, Caroline. We've got a window for data entry of 2 months in the protocol. So 1st of July would fit perfectly well with that. I think there is a sort of time pressure of making sure that this data collection is timely and relevant. So if we could have the data the next 2 months, it allows us to do the analysis and get it written up relatively soon. As everybody knows, sometimes getting the data is difficult, and certain centers will have many more patients than others. So I think if you run into troubles with finding the patients, extracting data, or it takes longer to enter the data, just get in touch and we'll find a way of making it all happen.
Yeah, I mean, I think I'd like to endorse let's aim for the 1st of July, but in a collaborative spirit, we will be open to discussion about timeframes around that. But I think that's a useful goalpost to go for. So we're recording this session. We will send that out in the same way we did for Bronx Start. We'll edit it out and then make sure that your staff can see it afterwards. And I think if there's no other questions, I will start drawing things to a close. So thank you very much to Caroline, Mark, and Ruud, who have actually put a huge amount of work in behind the scenes, and certainly to be able to get this not needing consent, to get all the approvals in place has not been an insignificant undertaking. especially kind of in these COVID times. And this is going to be an important study for PERUKI because I think it is going to provide some meaningful information about a specialty condition, but from the ED perspective. And as Caroline was alluding to at the outset, that's just a really nice lens with which to look through kind of endocrine research through. We often get ignored or forgotten about, and this is a really good way to wave our flag. Okay, well, I'll call things to a close. We're emails addresses are as they always are. Mark, I think so. I'll leave it up to you. You will send round the video recording when we've got it and further information for teams to take on. Brilliant. Keep well, everyone. We will speak to you soon.